Hello and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to purposely speak to one of the heuristics that I use when describing approaches to how one would think about in practice or teach somebody to practice osteopathic manual therapy. Too many practices, too many times repeating the word and making myself stumble. So the one that I want to look at and talk about is be organized. Now, the first place, if you look back at the stuff that I've put forth over many, many years, and you look through YouTube, you'll see it in the assessment concepts. You'll also see it in the treatment concepts, but the heuristic or the rule of thumb or the choice-making framework is be organized. With respect to assessment, it's start in one place, go through in a sequential order to another place. So don't go from the foot to, say, the lumbar column, to the hip, to the shoulder, to the ribs, to the neck. Don't do that. Go from the bottom to the top or the top to the bottom. Go through in a manner where you're not missing things or you're jumping back between things, because it's going to be much harder for you to remember. You want to automate things, make them organized, make them smooth. So you start in one place on purpose, you go to another place on purpose in a generally linear fashion so that it's much easier for you to keep cognitive hold of. With respect to treatment, be organized means do things in a particular order. So if you think about the concept that I've put forth or the acronym that I've put forth as, again, a choice-making framework of PTB, the patient activity, so the patient is either active or passive, that's a choice. The tissue or tissues targeted. In much of the written material surrounding osteopathy, they'll talk about neurological tissue, they'll talk about fluids, they'll talk about fascia or soft tissue or bony tissue. That's probably inappropriate because you're working from the outside of the patient and you can't truly interpret what's going on inside. You can get proxy information that can get you close, but you can't really get it. So with respect to tissue or tissues targeted, it's just the area that's not moving. It's really that straightforward. So although the tissue or tissues targeted is an omnipresent feature of all varying forms of osteopathic systems, be they a fascial system, a visceral system, a cranial system, they point at tissues that they're targeting with respect to how they interpret what they find as the proxy information outside. You don't have to worry about that. It's just the thing that you find that's not moving. Then the B is the barrier concept. You choose to go direct, you choose to go indirect, or you make no choice and you go indirect followed by direct. If you want to go direct, it's because you go in the direction of restriction and the patient doesn't show any protective behavior. So they're not jumping, they're not contracting heavily, they're not making any abrupt noises to abrupt movements, and they're not making any abrupt faces to abrupt movements. That's fine for going direct. If any of that happens, they have any abrupt response to abrupt movements, you go indirect, you make the soft tissue soft. So there's a bunch of choice-making frameworks here. But the be organized, PTB, patient activity, tissue or tissues targeted, and barrier helps you be organized. Then when you actually start to consider how you're going to apply something, you can go active, patient active, and you can test whether or not, prior to you adding the patient activity, whether you approximate things, so compress, pull things apart, distract, rotate things, torsion, or slide things, shear. You can do all of those things, figure out which one or one of those works well together, then add in the patient active. Now, when I suggest patient active, I suggest that you don't make the thing that you're working on the point of patient activity. So if you're working on the neck, I wouldn't suggest that you contract the neck. So if you're turning it to the left, I wouldn't suggest trying to contract it to the right, because it's quite uncomfortable. What I would actually say is use the concept of relational motion. So if we turn the head to the left, I would ask the person to turn their shoulders so they could, if they're in supine, they can push the right shoulder back, the left shoulder back. They could twist their torso to the left or twist their torso to the right. So it's a patient active approach without contracting the thing that you're working on, which has a higher degree of likelihood of being uncomfortable. But all of that to get to the point of those are things that help you with the concept of being organized because they're choice points. But being organized, the underlying phenomenon that I've been able to observe in attempting to get people to learn this profession is that the first thing that they try, so they start off by being organized. They say, okay, I'm thinking about going patient active and I want to test these things. So if we have the example of the neck and the patient is in supine, they'll ask the patient to push one shoulder backwards. And then because they get some form of connection that they want into what they're palpating, they stop there and they repeat it. As opposed to, regardless of the first thing I try works or not, I would try the right shoulder, and if it works, that's great. But I need to, at minimum, try the left shoulder. If the left shoulder does better than the right shoulder, and I only do the right shoulder, I'll never know. If I check the right shoulder and the left shoulder and they do something positive, that's fantastic. Then I can have the patient in supine push their right leg and their left leg into the table, because as they push them into the table, the torso, the body, is going to move in relation to the relatively still head and neck. Now, maybe it does what I want, maybe it doesn't. Maybe it does it better than the right or left shoulder. Maybe it doesn't. But I don't know if I haven't examined it. So just because the first thing you try seems to do what you want, you should still check the other things that are in your organized list to see if they also work or work better with respect to your desired outcome goal. This then relates relatively well to the concept of falsifiability within the scientific method. So within the scientific method, as it is most commonly practiced currently, there's the idea that comes from Karl Popper as maybe the person who made it everybody most aware of it. There is likely an identifiable arc prior to Popper that sort of had this in it, but Popper probably made it the most explicit. The concept of falsifiability means that I have a hypothesis. My hypothesis has to be a set of predictions as to how I fundamentally believe that a thing is going to behave. Now, to prove that it is that, I actually have to try to break it. So if I just set up an experiment where it would show that it does what I think it does, that is not the appropriate way. To know that the thing behaves the way I think it's going to behave, I have to try to test it to see if it won't. I have to try to break it. So if I think, in the case of a patient active approach with left rotation of the neck, if I think that pushing the right shoulder down into the table is going to give me the thing that I want in the neck where I'm palpating, then to know that that's the thing, I have to test the left shoulder. I have to test the right leg and the left leg. Because if the right shoulder does it the best, I know that it does it the best because I tried the other ways. I tested it in a way that would break my prediction or break my hypothesis. So my hypothesis simply is I turn the head to the left, I push the right shoulder into the table as a patient active approach, it's going to do everything I want in the neck. If I only do that, I will never know if it's the best. If I push the right shoulder, and I push the left shoulder, then I push the right leg, then I push the left leg, and then even I push both shoulders, I'm able to develop a hierarchy of what works best for that patient in that moment, for that method, and know that it's correct because I tried everything else. So again, if you try something, you have an outcome goal as a hands-on therapist, and the first thing that you try seems to give you what you want, don't stop there and settle on that as your method. Test the other ones. Be organized in your approach. Test other things to make sure that what you did first was actually the thing that's going to give the patient the best outcome in that moment based on the presentation and based on the method or the hold that you're using. Go through it all just to be sure. Once you try the different approaches, so if you were going to go patient active and patient passive, well, or you wanted to compare, what you would do is you'd take the neck, you'd turn it to the left, you'd add some compression, some distraction. You've already got the rotation. You can add very, 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 very light side bending, I would say, to see if you can sort of get it to all line up and add tension without a protective response, or make the soft tissue soft, whether you're going direct or indirect. See what that's like. And then if you want to know if it's the best, then you have the patient push the right shoulder, left shoulder, the right leg, the left leg. And if doing any of the active stuff doesn't give you more of what you're looking for with respect to the method or the outcome goal, then you know the passive is better, right? I would generally say that when you use patient active, it increases the general intensity of any method, and not necessarily intensity meaning in a good or bad direction. It just makes things more forceful because the patient's becoming active and mobile. So you clinically, from experience, you can often go passive, and if passive doesn't work, you add active. So you sort of shortcut the attempt to figure out the best method by choosing one first, and if it doesn't work, you go to the next one. So if you really want to know which one works best, you probably have to do them both and compare, because that's the most appropriate thing to falsify your prediction. If your prediction is that passive will work first all the time, then you have to do passive and active and compare them quickly to figure that out. To reduce cognitive load, what you would end up doing is choosing active first and then going passive, or choosing passive first and then going active. But if you want to know which one works the best, you have to compare them against each other, because that then satisfies the concept of attempting to falsify your prediction. So we've talked about PTB, I've talked about being organized with activating force, squish them together, compression, pull them apart, distraction, twist them, rotate or torsion, and then slide them is shear. Now, in every hold, you won't have all of those movements available to you. In every body part, you won't have all those movements available to you. So you do the best you can with the trade-offs that any hold provides you. And then if you add on to squish, pull, twist, slide, if you add on to that patient active as the next thing, you can't simply stick with patient active over here. You check them all, or all the options that you have available to you to figure out which is going to work the best. You work with that. And interestingly, let's just say initially pushing the right shoulder down, because I've checked everything else is the best, I'll do that. It will stop giving me anything. Then I test whether or not the left shoulder does something. And often when I have the patient push the left shoulder, after the right shoulder stopped giving me any form of connection or any form of result, now the left shoulder will give me a little bit more and a little bit more. But I won't know unless I check. So being organized allows you for a consistent way to move through approaches and layer them on top of one another, such that any hold gives me a large amount of permutations of ways to apply treatment with that hold. The choice is, again, is the patient active or passive? What tissue or tissues are you targeting? And the answer is the stuff that doesn't move that you found through your assessment, your organized assessment. And then the barrier, if I go into the direction of restriction, do they say ouch, or do they protect themselves? If no, I go that way. If they do say ouch, then I go indirect. I'll make the soft tissue soft. If I don't want to make a choice, I make the soft tissue soft, and then I add tension without them saying ouch or short of them saying ouch. That's obviously stated quite fast, but that is the fundamental concept of how you figure out what treatment is going to be the most appropriate. You don't figure out what's going to be the most appropriate if you don't check multiple angles or multiple approaches with any given hold, with any given patient, and then recheck them to see if the one that worked the best has stopped working, or when it does stop working as well as you want it to. Then you can go down the line again. So you have choices, you have more ways to get more of a result in a very respectful way out of that patient. So considering these things, pulling these things together, working with them, it all ends up stemming from the concept of be organized. Start with one thing, have a set of things that you're going to do subsequent, and then those things are described by other heuristics. They start to layer together so that you have a basic framework that you can take from one place to the other, instead of trying to take the method from one place to the other. Because another thing that will often be noted in any hands-on therapeutic approach with respect to education, be it chiro or massage or physio, whatever it happens to be, one of the more common questions that you'll see people in learning positions ask is, what was your hand doing? What was your hand doing? How did you have your hand? Or how did you do that movement? People are asking for details that will have to vary between myself and any individual that I would be interacting with as a patient. So each patient is different, and I am different than each practitioner. So we have all these variables, that make it so that if I tell you exactly what my hand is doing, it's not going to help you as well as you would want it to. The thing that transfers from one circumstance to the other circumstance is not the details of what I did with my hand or what anybody else does with their hand. The thing that transfers from one circumstance to another is much more so the abstract framework that allows you to choose which details to use. And that is how one would describe far transfer. So far transfer is really about things that you can't see or touch, but will guide your behavior and especially with respect to the choices that you would make to solve the problem. So you could call far transfer a problem-solving schema or a causal plot and story. But in the case of therapeutic approaches, it's really a problem-solving schema. So if I can give you a set of concepts that will allow you to choose what to do, regardless of what is in front of you, then you can start to add the details. So the thing that matters more is what guided any individual in making the specific choice they made in that moment, not necessarily what they did with their hand. Now, what they did with their hand is guided by that abstract, non-tangible, portable framework. So the reason that I suggest the heuristics is, and I point to them in all the demonstrations that I do, is because that is the thing that will guide you to figure it out in the way that you need to with the person who is on your table, as opposed to the way that I did it because it's me and because it's that particular person in that particular moment. I want you to be able to pay attention to the circumstance as best as you can and make appropriate choices with a consistent framework, as opposed to a consistent move that you have to remember. So you have to remember step 1, step 2, step 3 as far as how I do the move. And if it doesn't work for that person isn't responding properly, you may not notice. I'd rather you have an abstract, non-tangible decision-making framework that you can add any detail that you need to in any given moment that you need it. So the be organized concept helps me to help describe how somebody would go about solving the problem and the unique problem that's in front of them with respect to identifying and restoring motion to the best of their ability to that particular individual in that particular moment, as opposed to say, hey, remember that you have to do this move first and this move second and this move third and this move fourth in this order, and it'll get this percentage of the population moving better. Yeah, maybe it will, but not necessarily on purpose, not necessarily accurately. It's more by repetition and accident than on purpose. The way that I'm suggesting that you do it is to do everything very much on purpose in a very clear, organized way based on the response of the patient in that moment. Now, saying this obviously has a level of abstraction. So if you take this and then you go to the YouTube channel, the Osteopathic Lyceum, and you look at all the demonstrations that are there, or you look at the playlists that have these assessment concepts, treatment concepts, hand postures, multisensory integration, things of that nature, you can start to see how they layer on one another, and you can pull that into your own approach, right? So hopefully, if you've listened this far, some of that helped sew it together conceptually, and then go look on the YouTube channel and see the demonstrations, which we are trying to add as many more demonstrations as we can so that you can see these concepts over and over and over, and you can see me refer to them in important ways so that you can start to, again, layer them. So thank you for listening this far, and hope you learned something. We'll talk again soon.